Hi there, my name is Carly Endries. I am the Senior Project Coordinator for the North Dakota Brain Injury Network. I apologize that I'm not live today, but one of our providers requested a training at the exact same time, and so we had to make that work for them. So I thank you for your flexibility, but I was asked to come talk about unmasking brain injury today. If you're not familiar with us, our website is www.ndbin.org. We have a 1-855 number that is listed down below, 855-866-1884. A live person, Nikki Livdahl, our resource facilitator, answers that Monday through Friday from 8:30 to 4:30 type times. And we also have a generic email, or you can email me too, which is carly.endries@und.edu. But all right, I'll dive in here because I have about 30 minutes of your attention, so thank you for that. All right, so what does brain injury mean? Let's define it first so we're all on the same page. So the right side is North Dakota's jargony definition from Century Code, right? But basically it's saying that brain injury is anything after birth and prior to degenerative dementia. So we serve all of those. So we serve birth to death, as long as the injury happened after birth. So the individual was born typical, and then there's some type of life-altering event that changes their brain chemistry, then we can become involved. And yeah, so basically there are two types of brain injury. Acquired brain injury, or an ABI, is the umbrella term, but there is a TBI, or traumatic brain injury. So that's what most people think of when they think of brain injury, right? So those are those external forces. Those are assaults, falls, blast injuries, motor vehicle crashes, all that kind of stuff. So something outside coming into contact with the body. But then we also have non-traumatic injuries, so a little more of an internal event. So things like strokes and tumors. Anoxic injuries are interesting. So those can be near drownings, but those can also be drug overdoses. So if you've had someone that has needed to be Narcaned, that is an example of a brain injury, because that is oxygen restriction of the brain. Aneurysms, infections, so things like long COVID have been causing brain injury. Meningitis and encephalitis would be examples of brain injuries that are non-traumatic. So we serve both of these. So if you have someone that meets the requirements of that, they can work with us, and we do not require a formal brain injury diagnosis. We only require self-report. So we don't need any kind of specific documentation to work with that person. So this is kind of stats now on TBIs, so traumatic brain injuries. Basically what's happening, we're seeing more people survive catastrophic injuries, and there's a lot of reasons for that. Medical technology advancements have gotten amazing. 911 calls get to places faster now. There's just a lot of different things. People wear helmets and seatbelts, and all that prevention type stuff is helping people survive, but there are still a lot of people living with long-term effects of a brain injury. These are the leading causes, again, of TBI. So innocent enough, a fall, slipping and falling is the most common brain injury nationwide. When we look at just North Dakota, we are consistent with falls as well, but our reason changes a little bit. So slipping and falling on ice in the winter is the #1 cause for brain injury in North Dakota. So keep those sidewalks clear, wear those spikes on the bottom of your shoes, all that good stuff. Just try to really be safe in the winter. Here's our severity continuum. So this is something that the doctor's office is going to use to determine TBI severity. So again, TBI. So did you lose consciousness? LOC stands for loss of consciousness. So the longer you are unconscious, the more likely you are to have long-term impairments. So someone that was in a coma falls in the severe category, and about 80% of them have long-term impairments. And then it ranges from mild, moderate to severe. So mild injuries are loss of consciousness less than 30 minutes. So concussion is a brain injury, and not too many, but some people will have long-term impairments even just from that concussion. So we need to take concussions a lot more seriously too than people tend to. So brain injuries again are like a spectrum. There's a lot going on. So we do not have earthquakes, thank goodness, here in North Dakota, but we all are aware of what they mean and what they are. So we can have a devastating earthquake, like the picture on the top, right, where things fall down and it's just the whole city is ruined. Or we can have small little earthquakes where there's a crack in the sidewalk or books fall off shelves and that kind of stuff. Same thing with brain injury, okay? But there's still something wrong. So mild injuries do not always mean mild for the individual that sustained that injury. We've kind of gotten away from saying mild, moderate, severe at the Brain Injury Network. We usually just say brain injury. We don't usually label severity because it seems that outsiders that aren't familiar with brain injury, they seem to think then if it's mild, it should be mild for that person, and that's not always the case. Okay. So roughly about 12% of the general population have a brain injury when we look at various studies. But when we look at special populations, they are overrepresented with brain injuries. So look at the homeless. 50% of those homeless have a history of brain injury. And that is prior to their brain injury happened prior to their homelessness. So we are missing a lot of these people that have a brain injury that need our support and services that just can't seem to adult, right? So they need support. Behavioral health, so that is our mental health and our substance abuse individuals. There are about 60% of those have a brain injury. Those involved in the criminal justice system are about 60%, and actually it depends on the study that you look at. So we've seen, with juvenile justice, Minnesota did a study a couple years ago, and their juveniles came out at 99%. I've seen 87%. I've seen very high numbers. And then IPV stands for interpersonal violence. Those individuals that have experienced domestic violence or interpersonal violence in their lifetime, 75% of them have a brain injury as a result of that violence. So kind of the downer about brain injury is that there is no cure. So a lot of people do recover rapidly though in their first 6 months. So they get really excited and hopeful, which is great. We want them to keep that positive attitude, right? But it's probably going to slow down a little bit too. So sometimes we have to be the bubble burster when people say, but I was doing really great and now all of a sudden I'm not. And it's like, well, it is a chronic condition. There are things that impact brain injury, symptomology from day to day. It could be, did the person sleep good the night before? Is the lighting in the room bothering them? There's all kinds of factors that can relate to their successful recovery, but we never really consider their recovery to have an end. It's a cycle. It's a chronic condition. There's a lot of things that predict that. So the severity of the injury, the age you were at the time of the injury. So with our children, and I forgot to mention that when we're looking at that severity continuum from a few slides ago, the tricky thing about that one and to keep in mind is that children don't always lose consciousness. So a lot of times those individuals get forgotten about, those kids that were in a bad accident, but they didn't lose consciousness. Children's adrenaline is different than an adult, so it kicks in and it has a lot less body to pump through, so they stay alert and conscious, so they kind of get overlooked sometimes with the doctor. So yeah, your age also is a factor, because if are you maintaining skills or are you acquiring skills? So for an adult to have an injury that already has developed, typically, and now is, in the adult world, is going to look a lot different than a child that hasn't even, acquired the skills of all the skills that their brain can do yet. So, and then we have aging as well as a component. So if someone has their injury, in their late 60s or something, they're they're also fighting aging and a brain injury. So that can have different factors for them. Unfortunately, insurance is a major factor of recovery. So do you have good, appropriate acute care, and do you have access to good rehab? That can improve your outcomes a lot. And then your family life and your support system. So do you have a loved one you can call when you need help and when you need support? That can go a long way. So these are all possible consequences of a brain injury. So our brain controls everything that we do. So the outcomes can look very, very, very different from person to person. So we always say, you've met one brain injury survivor, you've met one brain injury survivor, okay? But these are all things that some of them struggle with on and off. So the orange box is the biggest because that is the one that if we could change, we would wave a magic wand and this all would go away. But unfortunately, that's not reality, right? So fatigue, someone with brain injury has double fatigue. They have a primary fatigue from the injury itself. So our brain is responsible for our arousal and keeping us alert and breathing and all of that. And then they also have a secondary fatigue. So they have fatigue from trying to keep it all together. So brain injury is one of those unique disability areas in that there's a distinct before and an after. So usually, depending on the age that the injury was sustained, that person knew themselves before, and now they're different. And now they have to accept that. And now they have to try to figure out how to navigate life with brain fog and with, sleep disturbances and all that kind of stuff. So there's this depression and anxiety and all these cognitive factors that go in that really influence them. So that's fatigue, lack of awareness as well. So they may have done things before their injury that now they can't do anymore, but they don't quite get it and they don't want to. And then, so not that they don't want to, but they just can't. So like, let's say I drove before my accident and then I have an accident and you take away my license because my reaction time has slowed down. That's going to be a really hard thing for me to accept and understand as well. Because if I was used to just hopping in the car and getting where I needed to go, and now I can't, that's hard. That's a loss of independence, right? And there's a coming to terms with that, of finding a new normal type piece. And then inconsistency. So sometimes what works today might not work tomorrow, but it might work the following day with someone with brain injury, and that can be frustrating for like the staff members of this client or survivor. Physical changes, very common after brain injury, but those are the ones that really resolve themselves pretty quickly. We hear probably the least amount of complaints about physical. I mean, I do hear about headaches, and maybe someone, will have some pain, residual pain type stuff, but we hear very little about physical stuff. People almost prefer physical because then somebody knows that something's up and like, oh, this individual has something wrong with them, or they need a little extra support. So that's kind of why unmasking brain injury came to be. So I'll talk about that more in a little bit. Cognitive changes. So cognition is like our interpretation of the world. So brain injury is not intellectual. Your IQ does not change after a brain injury, but your cognition changes. So the way we present that learner information needs to change. We need to be a lot more visual. We need to be slower and just more prompts, but they know the answer. They just need more time to generate it and more resources in allocating how to use their cognition. Then the last one is emotional and behavioral changes. So this is the scariest part for the loved ones because this individual looks the same, but they're acting different. Okay, so a lot of times we need to figure out what their triggers are. Sometimes we need to track symptoms to see what triggers different symptoms and what makes these emotions and behaviors dysregulated. So again, this is brain injury is referred to as the silent epidemic or the invisible disability. We've heard both, but a lot of reasons why, a lot of times people forget about it. It heals, it happened a few years ago and we look the same. And so people are like, oh, they're fine now, but that's not always the case given it's a chronic condition. Sometimes there aren't conclusive measures. Brain injury is tricky. That whole mild, moderate, severe thing with the loss of consciousness is very subjective because not everybody loses consciousness, and it can just be tricky to determine. And also brain injury is not going to show up on like a CT scan. So brain injury is cellular damage. Brain injury is not structural. Structural damage is going to show up on a CT, but like a concussion is not. So people get really upset. They want to see their injury. They want to scan, but that's not always the case. We can't always provide that, especially here in North Dakota. You can get some fancy MRIs and things like that that will show them, but you're probably not going to be able to get one here. Individuals are often told they'd be fine. Many of our people are sent home from the doctor, and no fault of the doctor. It's really hard to predict. The brain is, I've heard it compared to the ocean floor to oceanographers to like a neurologist, right? It's just so vast, and there's so many things going on within it, and all these intricate details that we don't always know what the outcome would be, and it can take a while sometimes to actually see the outcome of the injury. A lot of injuries go unreported or they're non-accidental, so people get worried, if we do have a drug overdose, we're less likely to go in, right? Because we were probably breaking the law at the time of the overdose. Or if I was beaten by my spouse and I love my spouse and I don't want them to get in trouble, I might not go in, okay? Minor blows to the head are not often viewed as brain injury. A concussion is a brain injury. Okay, I can't say that enough. A lot of people seem to kind of poo-poo concussion and it's no big deal, it's just a concussion, but concussions are a lot more serious than people realize. And once we've cracked that foundation, it can be hard to repair, or it's hard to heal. So a concussion should heal itself within 4 to 6 weeks. But we also need to keep that brain safe in that 4 to 6 week span. And once you've had one concussion, if you sustain another, you're 3 more times likely to sustain a second. And then after your second, you're like 8 times more likely. So it just has a compounding effect. So please be careful and wear those helmets and seat belts and all that good stuff. So unmasking brain injury. So this is a national awareness effort. This was not started in North Dakota. This is something that was started in North Carolina by Heinz Feet Farms, which is like a rehab camp that a lot of brain injury survivors go to. And they started this as a therapy project for survivors. So individuals are given a blank mask and a ton of art supplies and time together. And we decorate masks, and it's so therapeutic and it's so powerful. And basically they're supposed to tell their brain injury story with their mask, on their mask. And then what we do with them is we mount them like this. So these are actually our masks. This is here at the North Dakota State Capitol. And so we display them like this with a short little bio. We usually use the individual's first name and their last initial and the city where they were from or where their injury happened, whatever they want to put. And then a little bit about their injury and their mask, and then they decorate, and they're so powerful. Makes me a little emotional even thinking about them being up. But if you ever get a chance to see them in person, I highly recommend coming out and taking the time to walk through and read all these different people's stories. But they are also available on our website. So they are archived, and you can see we have about 150 in our collection. Our collection grows every year because we hold unmasking events every year, which you are welcome to schedule and host. So basically we bring all the supplies. We just need you to help us find the people and the space. So we bring everything else. Very fun events and very therapeutic to survivors. There are a lot of common themes when we look at unmaskings that people come up with. You'll see, so like this woman here, and there's a few others that did it. We'll do a lot of splits down the front of the face, and so there's a distinct that before and after piece, right, that I talked about. A lot of individuals do something with the mouth to represent either a change in speech or possibly not feeling like they have a voice anymore. I've seen people put a zipper over the lips, and I've seen people sew it shut and all different kinds of things. But you can see here a wide variety of people and ability levels and creativity. Staff members have started doing them. So this is an awesome crew at Essentia and some of these staff, so like right down here, and they all chose to decorate a mask because brain injury impacts all of us. It doesn't just impact the survivor, it impacts their loved ones, it impacts those that are providers of their care, and so I think it's important for more than the survivor to make the mask. So like this is a father, or excuse me, a son and mother group here, and these are her girlfriends. Everyone should come and be involved as they can, and they are really, again, therapeutic times for us. So other than scheduling and unmasking, we want you to have this on your radar as well. So we did develop a screening portal. And we have a really slick screening that we borrowed. The brain injury world is very, very collaborative. So this is from Ohio State University, and Dr. John Corgan gave us permission to use his lifetime history of TBI and other acquired brain injuries. So this one does cover both of those non-traumatic and traumatic. So there's 4 questions. This takes about 5 minutes to implement. Again, a screening is not necessarily a formal diagnosis. If someone wanted to pursue that, they would need to schedule a neuropsychological exam. But this has been shown to be very accurate. So usually someone that screens positive does eventually qualify for a brain injury diagnosis. But right now at NDBIN, what we are doing is we are screening at all over the place in different places. And if you would like to start screening, you are more than welcome, and we would love to train you on it and help you through that process. A lot of different agencies are screening, and homeless shelters and places like that. But yeah, let us know. You can contact me to schedule that training. But anybody that says yes to any of these is considered a positive screen. And then we move on to a symptom inventory, and that was developed by a neuropsychologist out of Colorado, Kim Gorgans, and she's amazing. She actually spoke at our conference last year, and she saw the need for this because, so say I screen positive and I do want a formal diagnosis and I want to go get a neuropsych. Scheduling a neuropsych is at least a couple months. So what I'm finding, it depends on the area, and there's not a lot in North Dakota. So Grand Forks, we have 1, in Fargo, there's a couple, and then in Bismarck, there's a couple, but there's maybe 5 throughout the whole state. So there's really not many. So the wait can be long. So it's a long time for that person to know I have a brain injury, or I might have a brain injury, and what am I going to do about it? So the symptom inventory is kind of our, what are we going to do about it? So it's intended to be a placeholder for a full neuropsych battery. So it's divided into 9 different sections, and each section is an area that the brain is responsible for. And the results come out very slick. It really works well. I've done this with people that we've, weren't quite sure, they maybe had a minor loss of consciousness years ago, but they really struggle with their mental health, and they will not score high on this. So this has been shown to be very accurate for those with a significant brain injury and their needs. And so then once they take this and we score it, then what happens is they're given tip sheets that match their symptoms. So one of those sections in those 9 sections was looking at the individual's attention. And so there's a tip sheet for attention that the front has a basic definition and then things to look for if you struggle with attention, some stuff you might notice about yourself. But to me, the really good part is the back, the accommodations. So what are we going to do about it in our day-to-day life to help us get that number better from that symptom inventory, to help it bother us less, right? So, these are some things that we would recommend trying. And we also have one for professionals. So one thing NDBIN is really trying hard to do is to demystify brain injury for other organizations and make you an informed brain injury organization. You guys are medical providers, so you are the brain injury informed, right? But there's a lot of professionals, social workers, agencies, parole officers, all kinds of professionals working with individuals with brain injury that don't necessarily have all those cognitive type accommodations just at the ready, or they just don't always know how to implement. So the ones for professionals give that advice, or how can I help this client manage their symptoms from their brain injury? Because again, it's chronic, it's not going to just go away, but there are a lot of things that we can do that are actually really very simple for the most part. Look at these ones, working in quiet places, using visual aids. So that's even asking like, hey, do you mind printing this PowerPoint for me so I can have it in front of me? And a lot of it's self-advocacy and teaching self-advocacy. Or, I have one gentleman that loves to wear a baseball cap when he's in places with bright lights. And so he emailed once for our conference and he was presenting and he said, do you mind if I wear my hat? Not at all. If you just ask, Most people are willing, but it's the asking part that's a struggle and that we have to really teach. One thing with brain injuries, this population is you have to be very explicit with this population. You have to explain everything and really help them through problem solving. And so these tip sheets go a long way when implemented appropriately and when people start to try some things on them on a regular basis. Please feel free to check out our website. This is an old screen grab clearly, but lots of updates on there from now. But our website is ndbin.org. There's a ton of great info. Upcoming things, we have a concussion symposium, we have our Mind Matters conference. You can order free decks of playing cards, ID cards, all kinds of good things on our website. But if you do want to make a referral, those are up in this top right where it says client referral. That this stuff doesn't change, you know, across the top and whatnot. It's just the more headers that change. But click there, client referral, and there's a form, and you fill that out and send it in. So we take referrals from the individual themselves, from a provider, and from family members. So we can accept them from anyone, but feel free to make referrals. The referral form spells out all of our client specific trainings, and we offer a survivor connections program where we pair up a veteran survivor with a newer survivor, and they have a 3-way phone call with our resource facilitator. Lots of different things that we provide. So looking at those, looking at our website, you're going to find a lot of great information. And that is all I have for you today. So I thank you so much for your time and for listening to what I had to say. And I hope you found it helpful for what you do and maybe learn something new about brain injury or, yeah, so contact us. There's our number and there's our website, ndbin.org. Okay, thank you.